of the CRAB symptomatology, it is important to consider that patients in which we suspect the possibility of smoldering can present some concomitant diseases in which the symptomatology can potentially mimic the myeloma symptomatology. And this is the case of patients with some increase of the serum creatinine due to diabetes or hypertension, or maybe iron deficiency or vitamin deficiency resulting in some degree of anemia. So we have to consider these concomitant diseases before doing the diagnosis of myeloma, because maybe the diagnosis is asymptomatic multiple myeloma. The second important consideration before doing the diagnosis of smoldering is to repeat the hemogram biochemistry as well as protein studies, maybe in 2-3 months' time since the first time we see the total proteins elevated together with the detection of the M component. Why? Because in these 2-3 months, we are going to see if the M component is stable or the M component does evolve, and especially we are going to see that the hemogram and the biochemistry remain stable. And if this is the case, we can confirm the diagnosis of smoldering myeloma. For doing this, as I previously said, we have to confirm that there is not any myeloma-defining event. We know very well the meaning of CRAB symptomatology, but according to the new criteria, as I previously said, published in 2014, you know now that it is possible to diagnose smoldering myeloma it is possible to do the diagnosis of myeloma together with CRAB, but it is also possible to diagnose of myeloma patients with more than 10% of plasma cells with no CRAB symptomatology, but any one or more of these 3 biomarkers: clonal bone marrow plasma cell higher than 60%, serum free light chain ratio higher than 100, of the presence of 2 focal lesions or more on MRI studies. I think that this is important because when we do the diagnosis of smoldering myeloma, this means that we have done the recommended workup in order to exclude the possibility of the presence of any one of these 3 biomarkers that in the past, in this case, these patients should be considered as smoldering, but now the presence of these biomarkers means that the diagnosis should be done myeloma. I know that there are some physicians in which they don't have any problem in order to call myeloma when the plasma cell bone marrow infiltration is higher than 60%, or when there are 2 or more focal lesions on MRI. But there is sometimes a question mark for the presence of a free light chain ratio higher than 100. And we've seen in the clinic some patients in which the free light chain ratio was higher than 100, and maybe these patients did not immediately progress to multiple myeloma. The Mayo Clinic published some years ago this paper that I think that it is important. And as you know, in theory, there is a relationship between the free light chain in serum and the Ben-Jones proteinuria in 24 hours urine. So if you have in front of you asymptomatic myeloma patients in which the free light chain ratio is higher than 100, you can check the Ben-Jones proteinuria in the 24 hours urine. And if the expression of Ben-Jones proteinuria is lower than 200 milligrams in 24 hours urine in blue, you can see how the progression to multiple myeloma is definitely much more lower in comparison with those patients in which the Ben-Jones proteinuria is higher than 200. So I think that this concept is relevant because maybe in patients in which the only biomarker for doing the definition of myeloma is free light chain, the Ben-Jones proteinuria can help us to identify those patients in red in which we can consider and we must consider them as multiple myeloma. What is the prevalence of smoldering myeloma? This was something unknown, but thanks to the iStop multiple myeloma project, that this is a screening project conducted in Iceland with more than 400 MGUS detected among over 80,000 people older than 40 years in which the M component was checked, it was possible to see how the incidence of smoldering myeloma is more frequent than expected, and 0.5% in persons over age 40 can present smoldering myeloma. The high prevalence can potentially have implications for future treatment policies like early detection as well as early intervention. And indeed, in this I Stop Multiple Myeloma project, for me, it's important to see how those patients allocated to the control arm, in which any follow-up was done in order to see how the component evolved, had a higher probability for presenting any graft symptomatology or acute presentation. So in terms of screening programs for plasma cell disorders, precursors plasma cell disorders, although the answer today is not yet, maybe this can change in the future, and this project is going to help us in order to answer to this question. The second important consideration when we have done the diagnosis of smoldering myeloma is to evaluate the risk of progression to active disease. And this is extremely important. I would say that this is mandatory because when we compare the outcome for smoldering in comparison with the outcome for patients with monoclonal gammopathy, the MGAS is a disease in which the risk of progression to myeloma is 1% per year. But in smoldering, it is possible to see patients with 10% per year, 3%, and 1%. So the risk is different. This means that smoldering is heterogeneous. And I think that from the management point of view, but especially from the patient's point of view, it is very relevant to inform to the patient if the risk is low, intermediate, or high. And for doing this, it is possible to evaluate, as I am going to point out in the next slide, we can detect the risk of progression to myeloma in many different ways. But the International Myeloma Working Group decided to build a model utilizing clinical parameters worldwide available. And this is the 2020 model, in which we are going to consider serum M spike 2 grams per deciliter, pre-light chain ratio 20, plasma cell bone marrow infiltration 20%. If we have a patient with smoldering myeloma and the patient presents 2 or 3 of these markers, this means that the risk of progression to myeloma is going to be approximately 50% in 2 years. And this means that these patients should be considered as a high-risk smoldering myeloma. This definition can be complemented by the presence of any or more of these cytogenetic abnormalities. And with this cytogenetic information, the model is even more precise because we will be able to identify patients in which the risk of progression to myeloma is almost 60% at 2 years. It is possible to utilize these variables again in another way, evaluating this risk score with different points according to the levels of the free light chain and protein, plasma cell bone marrow infiltration, or FISH abnormalities. And again, it is possible to identify the high-risk subgroup of patients with smoldering myeloma. This is the International Myeloma Working Group risk model worldwide available. In Spain, and especially in Salamanca, we evaluated the plasma cell bone marrow compartment by flow cytometry. And here you can see how in patients with myeloma, the majority, more than almost 100% of the plasma cells are clonal plasma cells. But in patients with smoldering myeloma, normal and abnormal plasma cells coexist. What we did was to evaluate the percentage of clonal plasma cells within the plasma cell bone marrow compartment. And we've seen that when the majority of the plasma cells were clonal, more than 95%, and in addition, the patient presented immunoparesia, the risk of progression to myeloma was also 50% at 2 years, median time to progression 2 years, so in line with what we've previously seen in the IMWG model. Other models are possible, and it is possible to consider the Ben-Jones proteinuria, the evolving pattern of the M spike, or even the evaluation of imaging assessment like PET-CT. And we've seen that when these patients present a positive uptake in the PET, but no lytic lesions in the CT, these patients present also a high risk of progression to multiple myeloma. I would say that whatever model can be valid if you are able to identify patients with 50% of risk of progression to multiple myeloma. New models are emerging based on biological or molecular markers. This is the case of the MGUS-like profile phenotype, basically based on the presence of a lot of normal plasma cells within the plasma cell bone marrow compartment, and this subgroup of patients with this phenotype and gas-like profile do present a very low risk of progression to multiple myeloma. In the Spanish myeloma group, we evaluated also the presence of circulating tumor cells by flow cytometry, and when patients present at least 0.02% of circulating tumor cells, the risk of progression to multiple myeloma is also very high. Genomic profiling has been also evaluated, and it was possible to see how the presence of mutations in the DNA repair pathway in MYC, in the MAP kinase pathway, were associated also with high risk of progression to myeloma. And these molecular markers can be incorporated to the conventional 2-20-20 model. And this is valid, but the problem, of course, is the availability for this type of studies in whatever hospital. Now, I think that the future is also based on the dynamic models, because what we've seen until now is based on the evaluation at the moment of diagnosis at a specific time point. And the group of Irene Gobrial in Dana-Farber, but the group of Barcelona in Spain planned evolving patterns in which the M component or other variables in the Pangea model, including the free light chain ratio, the creatinine, the age, or the hemoglobin, were evolving over time, and this means that the risk of progression to myeloma can evolve also over time, and these dynamic models maybe can be more precise into the evaluation of the risk of progression to multiple myeloma. The ideal identification of the risk of progression to myeloma should include clinical and biological markers, but I would say that the 2-20-20 can be the starting point in order to evaluate the risk of progression to multiple myeloma. And based on this, I think that the management of smoldering should be risk adapted. Low risk should be managed like MGUS patients. Intermediate risk should be followed closely than the low risk, especially at the beginning, maybe during the first 2 years, doing hemogram biochemistry, and maybe it is possible to do bone evaluation every year, alternating MRI with PET-CT. But if after 2 or 3 years everything is stable, maybe these patients can be followed once per year like patients with low risk. And maybe the challenging situation is for high-risk smoldering multiple myeloma. And today, I have to say that there is not any drug approved for the treatment of high-risk smoldering myeloma. However, at the same time, you have to know that many years ago, the Spanish myeloma group, but also the ECOG group in United States, conducted 2 phase 3 clinical studies in high-risk smoldering myeloma, comparing observation with Lendex in the case of the Spanish myeloma group or lenalidomide alone in the ECOG group. These 2 studies were academic clinical studies in which the objective was not, of course, to approve or to register these drugs for this disease. And this is the main reason why there is not any drug approved for high-risk smoldering myeloma. However, in the Spanish trial that you can see here in this slide, the last update was done couple of years ago, with a median follow-up of almost 11 years, we compared the Lendex 2 years with observation. In the observation arm, the median time to progression to myeloma was 2 years. So this was indeed a group of patients with high-risk smoldering, and the median time to progression for Lendex was 9 years, with also benefit in overall survival. And the ECOG group reproduced this data, including some patients with a low risk and intermediate risk, but the major benefit was observed in those patients with high risk according to the 2020 model. Next step was to consider, from the research point of view, Lendex as a standard of care, and several phase 2 clinical studies decided to add ilotuzumab, ixazomib, or even carfilzomib. Sample sizes were rather small, and you can see here how basically all patients responded, and the follow-up was quite short when they reported 100% of patients alive and progression-free. For me, from my point of view, these results are quite encouraging, but I think that based on the nature of the disease, we needed to measure the efficacy of these combinations with more modern approaches beyond response rate and complete response rate. And this was the reason why next step was to plan more intensive options of therapy for high-risk smoldering myeloma, but in addition, evaluating not only complete response rate, but also MRD negativity rate. One of these approaches is the ASCENT study conducted by the IMF, International Myeloma Foundation, with KRD plus daratumumab, followed by consolidation and maintenance, total treatment of approximately 2 years, and the median follow-up at the moment in which these data were presented were quite short from my point of view, approximately 30 months. MRD negativity rate was 84%, and we needed to see how this PFS curve will evolve over time. The Spanish myeloma group did a similar approach without daratumumab, carfilzomib, lenalidomide, and dexamethasone, but including autologous stem cell transplantation, consolidation, and maintenance with lenalidomide for 2 years. Total duration was 3 years, 90 high-risk smoldering myeloma, and the primary endpoint was to evaluate the minimal residual disease negativity rate after transplant, but especially MRD negativity rate sustained 3 and 5 years after autologous stem cell transplantation. And because of the COVID-19, we had some bone marrow not done during the 3rd year, and this was the reason why I amended this protocol to evaluate the sustained MRD negativity 4 years after autologous stem cell transplantation, 2 years once the patients had finalized maintenance therapy. This study resulted in positive results. Honestly, we were more optimistic at the beginning. We thought that we were going to have at least 50% of MRD negativity rate 3 and 5 years after autologous stem cell transplantation. The reality has been that 31% of the patients maintained the MRD as negative 4 years after transplant, 2 years after finalizing the maintenance therapy. This is the time to progression to active myeloma, so the time to progression is quite encouraging. And the main reason is because we observed, as I am going to show you later, some patients who biochemically progress. And the biochemical progress included just the positivization of the MRD negative to positive. And indeed, we planned an early intervention with Dara-Pom-Dex in these patients with the objective to maintain to these patients without any myeloma-defining event. We detected that the achievement of MRD negative at the end of maintenance therapy was an important prognostic factor predicting progression to multiple myeloma. And a similar study was also conducted by the group of Ola Landreg with KRD 8 cycles, followed by Len maintenance 2 years. Like our study, without autologous stem cell transplantation. And the primary objective was also to evaluate the MRD negativity rate and the sustained MRD negative over time. And the results were quite similar to our data. Sustained MRD negativity over 2 years, 39% of the patients. So similar to our data with optimal progression-free survival, and they didn't plan an early intervention. But the common situation to these two studies in similar population is to see how approximately 40% of the patients biochemically progressed, and the achievement again of MRD negativity at the end of the maintenance therapy predicted biochemical progression. So I think that in this type of studies, we have to utilize MRD sustained over time, maybe as the primary endpoint. I think that we plan potentially curative options using sustained MRD negativity over time as a surrogate marker, because personally I consider that the delay of the progression to multiple myeloma has been already demonstrated, and when we plan just a treatment with Lendex, we are going to delay the progression to myeloma. The key question is if smoldering myeloma is biologically different to multiple myeloma, and the answer is maybe yes. This has been conducted by the group of Ola Landrek, but we have also reproduced this data in our study when genomic profiling for patients with smoldering myeloma and newly diagnosed myeloma was evaluated, and all patients were treated with a carfilzomib-based combination. Treated high-risk smoldering is less complex than newly diagnosed multiple myeloma with less complexity from the genomic point of view. Areas of improvement. Of course, we know that in myeloma and in smoldering myeloma as well, there is immune impairment. So it is possible to utilize this like an opportunity in order to utilize immunotherapy approaches for smoldering myeloma. This has been the case for daratumumab single agent in this phase 2 Centaurus study, dara monotherapy in 3 different approaches, but it is possible to see how there is a benefit in terms of delaying the progression to multiple myeloma. This has been the rationale for the phase 3 Aquila study that compared daratumumab single agent versus observation, and this study will be presented at us this year, and if the results are positive, I hope that they will be positive, it would be possible to have the first drug so far approved for high-risk smoldering myeloma, daratumumab single agent. But there are other 2 phase 3 clinical studies ongoing with a registrational purpose. Ithaca study, Lendex versus Lendex plus isatuximab, Lendex compared with Lendex plus daratumumab. In the first one, the primary endpoint is progression-free survival, and in this second one, the primary endpoint is overall survival together with the quality of life. But also the new approaches like the bispecific monoclonal antibodies had been and are being evaluated also in this population. And the group of Irene Gabriel presented at the last ASH meeting in 2023 the first report with 19 high-risk smoldering myeloma patients treated with teclistamab. Safety profile was acceptable. That what, from my point of view, is something crucial. But in terms of efficacy, and in spite of the fact that the follow-up is quite short, 100% of the patients achieved minimal residual disease negative. So we will see what is the outcome. And you have to know that some clinical trials are ongoing with BCMA CAR-T also in this population. So this is my last slide. I would say that smoldering is a precursor plasma cell disorder with a higher prevalence than expected. So it is possible to do the diagnosis of smoldering in a quite high proportion of normal population. We have to consider that the outcome is not uniform, and this is the reason why I think that the stratification according to the risk of progression to myeloma is mandatory because the management should be risk adapted. And we can't do anything if we don't want. It is not necessary to plan an early treatment, but the follow-up should be based on the risk of progression to multiple myeloma. There are many clinical trials ongoing, as I tried to show you during my presentation. I think that in the near future, we are going to have new drugs and new combinations approved for this disease, and further studies will help us to identify patients in which we can plan just an option of therapy to delay the progression to myeloma, but hopefully we can select in the future maybe patients in which we can plan a curative approach. And I stop here. Thank you very much, and happy to take your questions.
Thank you, Mariví. Thank you for this very, very comprehensive overview of smoldering myeloma, which I think it's a very, very fascinating field, way more complicated than multiple myeloma, because dealing with multiple myeloma is quite complex. But when you discuss the management of patients with a precursor disease that are healthy patients, I think it gets way more complicated. So before addressing the questions, I'd just like to ask you three very, very practical points. So in your clinic, who do you recommend to perform a bone marrow biopsy to evaluate whether it is an MGUS or a smoldering myeloma based on the M protein or free light chain? So what are the cutoffs that you use?
Well, this is a good question, and in principle, as well, I am based on an academic institution. We try to do as much as possible bone marrow aspirate, basically to every patient in which we detect a M component. It's true that maybe in patients older than 75 or older than 80, especially if the M component is IgG and the size of the M component is very, very low, we don't proceed to bone marrow. But in the rest of the patients, we do usually go to the bone marrow. You probably know that the iStop Multiple Myeloma Project launched a calculator in order to see, introducing the free light chain ratio and the levels of the IgG, IgA, IgM, and the size of the monoclonal component, the probability the patient will have for having more than 10% of plasma cells. Honestly, you have to know that we have tried to reproduce this model with our patients with MGUS because we have a lot of bone marrow dons, and we've not seen a high concordance. So, of course, I think that this should be validated, and we are going to publish this. And this is the reason why we do usually do bone marrow in the majority of the patients, and the exception will be maybe very elderly patients, very low M components. I know that the guidelines usually consider the cutoff of 1.5 grams per deciliter and IgG. It is not necessary in principle to go to the bone marrow, but from the academic point of view, maybe if it is possible and the patient does not present any rejection for doing the bone marrow, I do prefer to do this.
I was asking this because referring to the iStop study, the first results that they actually show that the median value of M protein in the serum is extremely low as compared to what the guidelines recommend. If I remember correctly, it's 0.5, 0. Grams of deciliter, which means that in our clinic, we are labeling patients with MGUS that are probably actually have smoldering myeloma.
Yeah.
And on the other hand, we could detect patients with smoldering myeloma with a way lower risk of evolution because now we do think that they're MGUS. So I think that is very, very interesting. Another question, very practical, is once you've established the diagnosis of smoldering myeloma, what is the first imaging that you request? Do you go immediately for the MRI or low-dose CT? And how do you I already mentioned this, but like from a practical point of view, what would you recommend?
Yeah, we do first the PET-CT because PET-CT is the standard imaging assessment we do in multiple myeloma. The reason is because we are going to use the CT part as low-dose CT in order to see if there is any lytic lesion, yes or not. If there is some lytic lesion, the diagnosis is myeloma, and it is not necessary to do anything else. If there is not any lytic lesion, we go to the PET, and we know that if there is some positive uptake with no lytic lesions, we know that this confers high risk of progression to multiple myeloma. But if a PET-CT is negative, the next step is to go to MRI in order to see if the patient presents or not focal lesions, one or more than one or zero. And this is what we do in routine.
And I think it's also important to remind everyone that if you ask for a PET-CT, you should be aware, you should be sure that the radiologist will also look at the CT part, because sometimes also the nuclear medicine will just take a look at the focal lesions, but we also need to be aware of the lytic lesions as well.
Absolutely. And I know that some people do first MRI. Well, I don't have any argument against it, but I think that with the PET-CT, we are going to see if lytic lesions are present or not. And sometimes if lytic lesions are present, it is not necessary to go to the MRI.
Another practical question is, you mentioned that the follow-up, of course, of these patients varies according to the risk of smaller myeloma. So when you first established the diagnosis, you said that you may want to see the patient in 4 to 6 months, depending on the risk, to also, I guess, evaluating the dynamic of the M protein and also maybe hemoglobin levels and stuff. My question is, for patients who have a low risk or intermediate risk smoldering myeloma, or even high risk but stable for many, many years, do you see in the future, given that if we biopsy every patient or almost every patient, we will have a huge increase in the prevalence of smoldering myeloma, incidence and prevalence, do you foresee a potential management between hematologists and general practitioners for this patient?
Yeah, sure. And this is a very important question, because otherwise, if we do early detection of many patients with plasma cell precursor diseases, including MGUS and smoldering myeloma, so we will increase the number of patients in our clinic. So what we do is, in patients with MGUS, in patients with low risk smoldering myeloma, or even intermediate with a stable situation for at least 2 years, we refer these patients to the general practitioners. We have an internal channel for communicating with them. They order once per year the hemogram biochemistry, serum protein electrophoresis. If they see any symptomatology or any sign of alarm, they contact immediately with us and we see the patient immediately. This is what we planned just maybe 2 or 3 years ago, because otherwise, well, our clinic was basically full of patients with MGUS, that at the end of the day, we decided to select a specific day for these patients, because it was even not appropriate to have in the same waiting room patients with myeloma receiving active treatment with patients with MGUS that maybe they are not going to progress to myeloma. They never will progress to myeloma. So we decided to change, and this is what we do.
Thanks for sharing. This is really music for my ears, because I've been discussing this for a very long time. Also referring patients, what we do sometimes is that we see the patient once every year or 8 months. And then in the meantime, we also ask the GP to test for hemoglobin values or creatinine clearance. And we tell them that if they see anything changing, they can contact us. But otherwise, I think it's appropriate for GPs that have the right instructions to follow these patients.
We have a model, a report model that we sent it to all general practitioners with the alarm symptomatology and the alarm sign in order then to contact with us.
And I think this is also has to attend every 4 or 6 months. That is a heavy burden also from a psychological perspective, going to a cancer center. And they always said that they're pretty anxious the days before. Instead, going to the GP may reduce also the psychological pressure. So we have a couple of questions that are, so this part was easy. I think now we can deal with the hard part. So we don't have a treatment approved yet, but if you had an approved treatment, what would be your approach to a patient with high-risk smoldering myeloma? Would you treat with a cure intent or control intent, or does it change according to the patient? Because I think 4 years old, 8 years old may be different, the approach.
I think that the approach can be different based on the type of patient, because I've seen in my clinic young patients with high-risk smoldering that they wanted to be treated like multiple myeloma patients. So our idea is to have almost always clinical trials active, but sometimes this is not the case. I have actually few, but some young patients with high-risk smoldering that they decided to be treated like multiple myeloma, and this is what we did. I recognize that this is a bit off-label because the patients, well, the diagnosis was high-risk smoldering, but in principle, if the patient is young, I do prefer to offer this potential curative approach. Of course, if the patient is elderly, so maybe we can just follow up, wash and white, or with lenalidomide or Lendex, we know very well the safety profile for this treatment, and we know that the progression to myeloma is going to be delayed. But honestly, outside of clinical trials, I've treated some patients with the intensive approach. I've never used Lendex in a high-risk smoldering myeloma off-label because we usually have other clinical trials.
And so you mentioned that based on the Aquila study, if the results will be positive, we may have in the next future the first drug approved for smoldering myeloma. But by the time we have daratumumab, single agent, given the results, because I'm sure that daratumumab is going to delay the progression to over myeloma, but we also know that single agent drugs and even combinations, we just saw at the IMS in Rio the results with Isa-Len with a fixed duration that the rate of CR is very low. So definitely you're delaying the progression, but you're not curing the patient. On the other hand, if you treat the patient with, let's say, daratumumab, this may have downstream consequences in access to clinical studies. And we don't know what the end results on an approach of fully transplant eligible patient, let's say a patient that then needs DARA VRD, will be. So would you, in a young patient, be confident treating a patient with a single agent or not? Because my feeling is that I would not be that happy.
Me too. I think that this is going to be difficult. Of course, we have to wait to see the results, but I think that there is another issue with the Aquila study, and the issue are the criteria. I personally consider that not all patients are going to be high-risk smoldering, because according to the inclusion criteria, some patients will present intermediate risk. But I completely agree with what you said. Daratumumab single agent maybe is not optimal enough for the early treatment, assuming the consequences, because this patient will never be eligible for clinical trials for multiple myeloma patients. And I think that this is going to be the main issue or one of the main limitations in order to implement the results of Aquila in the clinical practice.
You mentioned the applicability of the new scoring system to all the studies and the heterogeneity in how high-risk smoldering myeloma was defined. So I think that's one of the limitations in the interpretation of results from clinical studies. They all adopted different, and when you look at the concordance, as you mentioned, is never 100%. So do you, as you're a leader in this field, do you think that now that we have established that we do have highly active drugs, and you also showed the bispecifics, for example, with 100% MRD negativity. So now that we do have active drugs, shall we really, as a community, decide which one of the scoring system should be used once and for all and stick to it, so at least we will have an idea of what the results are? Because otherwise it's every study is criticized because the results are not could not be interpreted in the correct way.
Correct. You are completely right. And indeed, you know that the International Myeloma Society have, well, has a close interaction with authorities, especially with FDA. The first meeting we had with FDA, one of the topics was smoldering, and people from FDA told us, guys, please harmonize the criteria for the selection of high risk, but this is something that you should do because we are not going to do this. So I think that this is the reason why I said to 2020 maybe is far from being the optimal model, but this is worldwide available, and if we use all of us to 2020, we are going to harmonize the definition. And of course, we can complement with the circulating tumor cells, with the dynamic model, with the genomic profiling, and so on. But we have to build a model available in Italy, in Spain, but also in South Africa. And this is the reason why I personally consider that we have to use this type of models.
And do you envision in the next future a way to actually define smoldering myeloma based on genomics, for example? So biological characteristics rather than selecting a cutoff, which is 10%, which was fine when it was selected, but now we know there is a lot of heterogeneity, even in smoldering myeloma patients.
This will be the ideal situation, but not only applicable to smoldering. If we consider the spectrum of plasma cell disorders, gas smoldering and myeloma, there is a continuous. So the separation is completely artificial. But even for myeloma, what is the difference between ISS1 myeloma with 10 grams per deciliter of hemoglobin and smoldering with 11.2 grams of hemoglobin? So I think that this would be the ideal situation. And I think that the molecular diagnosis based not only on the plasma cells, but also on the bone marrow microenvironment, on the immune system. The problem is how this definition is applicable to the routine in every center. I think that this is not the case, and indeed we've been calling to multiple myeloma based on some criteria since many years ago, and I think that this is the reason why we do the same for smoldering and for MGAS, although of course I completely agree that the separation of the different entities is a bit artificial, of course.
We have another question. I think it's very interesting. Is in the scissors study, did you perform any genomic or even fish analysis after patient progressed with MRD resurgence or biochemical progression to investigate whether the treatment resulted into a selective pressure for higher, more aggressive clones or not?
Yes, but we have not evaluated this in detail. Bone marrows were repeated because once per year it was required to do MRD in the bone marrow in order to evaluate the sustained MRD over time. This allowed us to see biochemical progression in almost 40% of the patients. And indeed, these patients were included in a second study, and these patients are receiving right now Pomdex plus daratumumab. But we have not evaluated yet this second part of the study. And this is something that we'll do maybe in 2025. But of course, this will be interesting in order to see if there is a clonal selection or a reappearance of new clones responsible of this relapse, and if this has a relationship with the outcome we've seen once this patient had been rescued with the Pomdex.
And I know that you are going to publish this, but did you see, let's say, were you satisfied with the Pomdex efficacy in patients who were retreated, or was it as you expected?
Well, I repeat, we have not analyzed the data yet, but my impression is quite good. The majority of the patients I have in the clinic included in the Jim Cesar, the first disappointing result is the majority of the patients had to move to Darapondex because they biochemically progressed. But the response with Darapondex is even better than with KRD and transplant in some patients. So but this is just my perception based on 12 patients that we included in our center. And we are going to plan to evaluate the second part now once we have already published the first part of the study.
So I will end with a clinical case, but before that, I would like to ask you one philosophical question. What do you think should be the primary endpoint of a study testing a treatment for smoldering myeloma right now? Because we know with multiple myeloma, there was once overall survival, then progression-free survival, and now is MRD accepted as a surrogate endpoint. What do you think should be the ideal endpoint for studies to really demonstrate that early treatment, particularly with an intensive treatment, is worth?
Yeah, so I think that the primary endpoint should be MRD negativity rate sustained over time, because from my point of view, this is a clear surrogate marker for outcome. But you have to know that another issue with these endpoints is if we consider progression-free survival, for example, in the observation arm in the Aquila and in other studies, well, patient can potentially achieve complete remission. And as soon as the M component reappears, this is not an event, because we have to wait until the patient develops CRAB symptomatology or slim CRAB criteria. And this is quite difficult, especially for physicians, because it is difficult to maintain the patients on study when the M component is going up, but they have to wait until the CRAB symptomatology is present. This is the reason why, together with the MRD negativity sustained over time as the primary endpoint, in order to consider event, maybe it is not necessary to wait until the CRAB symptomatology is present. And just with biochemical progression, this should be considered as event, because I think that this will allow us to treat the patients again in a symptomatic phase. And maybe we can maintain smoldering myeloma patients treated with 2 or 3 different lines of therapy, but without any myeloma-defining event. But I recognize that this is difficult, and the different companies are working with authorities on this, but this is not easy.
There's another question, which is, so we stretch the definition of multiple myeloma to include patients with ultra-high risk smoldering based on the slim CRAB. And so the question now is, can we go further and include some of the current high-risk myeloma based on the 2020 and with other characteristics to actually recommend treatment also in this patient? What do you think?
Sure, I think that this would be the ideal situation, to expand even more the definition of myeloma, removing ultra-high risk smoldering myeloma to be incorporated into the definition of myeloma. And you know that the response criteria are going to be defined, and this is the optimal situation. But on the other side, the criteria for the diagnosis of myeloma can't be changed every other year, because these criteria are used by the authorities for the approvals and so on. So I think that this is an exercise in which we have to work, because for me, this would be the ideal situation, to expand the definition of myeloma, because this is even more easy from the practical point of view, because patients could be included in clinical trials for newly diagnosed multiple myeloma, and they could benefit from induction, transplant, CAR-T, or maintenance. So this would be the ideal situation.
So one last question. You mentioned at the beginning the issue with free light chain over 100 as a ratio and the Benz-Jones proteinuria to guide actually the decision of recommending treatment or not, because the free light chain was the weakest criteria among the slim CRAB. So I have a patient she's very young, 50 something, very active, completely asymptomatic. We did a whole workup. So MRI is negative, no anemia, plasmacytosis less than 60%, is actually, I think, 30-40%. But she has a free light chain ratio over 100. There was also an evolving pattern. So it went up in, let's say, 6 to 8 months. It was less than 100, and then it went up to more than 100. So this evolving pattern was a little bit concerning to me. And now she also has 200, exactly 200 milligrams of Benzjohn's proteinuria per day. So I really, and she's very, totally asymptomatic, working, was very afraid of starting treatment. She has a lot of knowledge, she studies, she goes online. So we discussed this, we discussed treatment. And what I told her is that I can either recommend to start treatment and get away with the issue, with the fear, particularly with the relay chain of renal failure, which may be the case. Or if she really doesn't feel like, we can work on a strict follow-up. And I told her all the data, and I think that now we've decided to move on. We also have a clinical study up front, so she's also interested in participating in the study. But I think that this is a very doctor and patient decision that we have to share with our patients, particularly young patients. So I don't know what you think about this, but hopefully you agree.
No, completely agree. And we have to practice patient-centered medicine, but I think that this is crucial in the management of smoldering myeloma. I completely agree with the approach you have decided to do with your patient, because if the Benzjohn's proteinuria is 200, so we have to take care with the renal impairment, and I think that this patient can benefit from the very good clinical trials we have right now for the first line of therapy. But we have patients with a high risk smoldering, honestly, that they are anxious because they want to be included in a clinical trial. Well, we are going to start a pilot study with BCMA CAR-T in high risk smoldering, and you can't imagine, but I have a waiting list because patients want to be included, and maybe we will have other patients that they don't want to be treated. But if you explain to the patients the situation of a high-risk smoldering, how they can evolve to myeloma, well, I don't know if I am a bit biased, but the first question the patients usually ask is, why don't you treat me? So we have, of course, to modulate, we have to explain them pros and cons, but if I have a clinical trial, for me today is the best option. And now we are going to include 2 patients between now and the end of the year with BCMA CAR-T, and we will see what happens.
Well, based on the results that were presented with the bispecific, I think that so the premises are very good.
Yeah.
All right, so I think we're at the end of this webinar. So thank you very much, Mariví. This was a very informative and also very helpful discussion. I hope that everyone enjoyed it as much as I did. So thank you, and thank you also to the sponsor. Thanks to the sponsor for sponsoring again this webinar. Hi everyone. We'll see you in a week with Dr. Usmani and high-risk myeloma, and enjoy your evening.
You too. Thank you very much, Roberto, and thanks to all people who joined this meeting.
Thank you. Bye-bye.
Bye-bye.